Good afternoon, and welcome to the Blanco Center's final installment in the Katrina Forward series. My name is Stephen Barnes. I am the Executive Director of the Blanco Center, and we are going to give one more minute for attendees to join the webinar, and we will begin shortly. All right. Well, good afternoon. We will get started now. My name is Stephen Barnes. I'm the Executive Director of the Kathleen Blanco Public Policy Center at the University of Louisiana at Lafayette. And I am pleased to welcome you to the final installment in our Katrina Forward programming, which has commemorated the 20th anniversary of Hurricanes Katrina and Rita, and really taken the long view in reflecting on 20 years of history, how the state has changed as we emerge from those storms, and thinking about the path forward for Louisiana. Very honored today to be joined by Shelina Davis and Mike Bertaut to engage in a rich discussion about health and healthcare, reflecting on how those storms of 2005 impacted and disrupted the healthcare sector, and some of the bigger changes to the healthcare system and to public health that came out of those storms, as well as the changes that have unfolded in the years since. We're going to start with presentations by each of our panelists, and then we'll have some time at the end for Q&A. So all audience members, please feel free to collect questions, and we'll take those via the Q&A feature at the end of the webinar. I'll offer some brief introductions first and then turn it over to our speakers. First, we'll hear from Shelina Davis, who is the Chief Executive Officer of the Louisiana Public Health Institute, a nonprofit organization that acts as an ecosystem connector, working at the intersection of health systems, community-based organizations, and residents to advance health equity. And we'll also hear from Michael Bertaut, who is a healthcare economist and exchange coordinator at Blue Cross and Blue Shield of Louisiana. He has 25 years of analytical experience in healthcare, telecom, and retail industry sectors, and tracks healthcare costs and the impact of policy reforms. And as I turn the floor over, I'd like to acknowledge that I also serve as a board member of the Louisiana Public Health Institute, and have been so pleased to be able to see and kind of help usher forward the great work that the Public Health Institute is doing. And I'm also a member of Blue Cross and Blue Shield of Louisiana as a policyholder. So great to have two well-known and highly regarded folks here to share their perspectives. But I'll turn it over first to Shelina.
Thank you so much, Stephen. And let me go ahead and share my screen. All right, so good afternoon. And again, thank you to Stephen and his team at the Blanco Center for having me today. I'm honored to be invited to share my reflections from both storms that impacted Louisiana back in 2005, and what that means for the here and now. So I was born and raised just outside of New Orleans in St. Tammany Parish. So I was definitely no stranger to hurricanes and floods. I moved to Orleans Parish for undergrad school at Xavier University of Louisiana, and then went to Tulane for my graduate studies. The weekend before Katrina hit, I was preparing to start my first week at Tulane, beginning a dual master's in social work and public health, ready to embark on a career focused on helping shape healthy and resilient and safe communities. Instead, though, I had to pack my bags to head to my parents, who had just relocated to Ascension Parish, along with about 20 family members who were in Orleans and Jefferson Parish, to wait out the storm, never realizing it would become one of the most defining moments of my life, both professionally and personally. Watching the devastation unfold on TV was surreal. I was fortunate to still have my home, even though it had about 2 feet of water inside of it. And while waiting to return to New Orleans, I dove right into helping our community. I volunteered at Lamar Dixon and Gonzales. Many of you probably remember a lot of folks went there to shelter. And it wasn't just people that were sheltering there, it was also animals sheltering there. Actually, my husband, and I didn't even know him at the time, was doing a lot of rescue of animals in the lower Ninth Ward and bringing them to Lamar Dixon. We were supporting families who couldn't get back home. I later started classes as a guest student at LSU School of Social Work and volunteered in Baton Rouge at the Office of Behavioral Health on the crisis line, where people just called, sometimes just to talk, just because they just didn't know what was happening and weren't getting real-time information about what was happening after the hurricane. When I did go back to New Orleans, I volunteered as a health coordinator of a health and wellness tent of a monthly farmers market in the lower Ninth Ward. And we not only brought mobile vans from community health centers at that time to help provide health screenings, but we also brought in alternative approaches to health. So we had a psychiatrist who also was an acupuncturist that provide acupuncture just to help people with their mental well-being. I also was a student worker and helped support a housing organization, and again was on the phone with many people trying to get home and trying to get housing. I just felt like I was called to this work in helping community as much as I could, particularly around health and wellness. And what really stayed with me from that moment was seeing how, even when Louisianans had just gone through one of the most devastating storms of their lives, Katrina first, and I know Rita on our west side, we still found ways to help one another, to connect neighbors to resources, information, as well as hope. And that spirit of resilience and community ultimately led me to my work at LPHI a couple of years after the storm. So in 2007, I joined LPHI, really as a early career professional to really rebuild and reimagine primary care services for our greater New Orleans region. So, as I shared a couple years after the storm, I witnessed firsthand how our healthcare system was completely decimated. As you all know, Big Charity had closed. Clinics were still struggling to get up and running. And many people, especially people who were uninsured, underinsured, or on Medicaid, had very limited options to turn for care. But that lack of resources and that lack of need within our community really sparked action and advocacy. Many local and state leaders, including my predecessors who were the leaders at LPHI at that time, joined together to advocate for funding to rebuild our greater New Orleans region's primary care system, particularly the primary care system that served safety net populations. And their tireless efforts led to a $100 million federal investment through the Centers for Medicaid and Medicare, through the Primary Care Access Stabilization Grant, or also known as PCASG. This was a quality improvement initiative and also really helped to enhance care delivery, where we helped provide technical assistance as well as funding to not only support service delivery, but support providers in providing them at the highest quality care that they can provide, and also ensuring that we were integrating not just physical health services, but also mental health and social services into that setting. And many people also know that these improvements also served as a bridge to Medicaid expansion as well. And that was written about in an article that I published with co-authors back in 2015 that talked about 15 years later paving the way for primary care healthcare system delivery. Additionally, that $100 million investment helped to establish and strengthen a number of provider organizations, including our community health centers, our behavioral health provider organizations, and social services organizations across the region. And we know that it wasn't just about rebuilding what we lost, it was also about reimagining how healthcare was delivered so that it could be more equitable, more community centered, and more resilient, both during times of disaster and during normal times as well. This initiative also ignited health systems transformation and social and cultural norm change. At that time before Katrina, we know a lot of folks sought their care in the emergency department or a big charity hospital. So we really also try to really change social norms to really seeking care within community-based primary care services, because we had those services in every neighborhood across the greater New Orleans region. So these early efforts really created a model for collaboration between government and philanthropy, as well as community-based organizations, and really laid the groundwork for partnerships that still exist 20 years later today. It also taught us a lesson that has shaped my entire career, that when systems fail, our communities really rise and organize and come together. And when we listen to communities, we find solutions that can be long lasting. So, over the last 2 decades, we've seen tremendous, bold, and visionary leadership, partnership, and collaboration, often, again, among the same people that I met when I was an early career professional, when I first began the journey, some of whom are still serving as leaders of many of the organizations today. Those early partnerships, as I mentioned, didn't just rebuild clinics, they built a foundation of trust and infrastructure that has supported our region through every crisis since. That foundation really allowed us to mobilize for recovery after the BP oil spill 5 years after Hurricanes Katrina and Rita across the Gulf Coast from Louisiana, Mississippi, Alabama, into the Florida Panhandle. It also has been leveraged to coordinate community response during other hazards or pandemics like the COVID-19 pandemic. And now we're leveraging this infrastructure that we created to navigate challenges like the Medicaid unwinding process. And really, through these efforts, we didn't just enhance the partnerships, we also deepened our infrastructure and understanding of critical data and health information systems. And those are the systems that we really leveraged to help us really monitor the impact these changes have made over time. Some of those examples of the data infrastructure that we've built in partnership with many folks through collaboration and vision include the Health Information Exchange that we now was formerly called the Greater New Orleans Health Information Exchange, but now that is statewide, it is called PELEX. We rebranded last year. And that is really an infrastructure that links community providers to real-time data so that they can improve the care coordination and care management for the people that they serve. Also, that success paved the way for another data and research infrastructure that we call ReachNet. And this is a regional research and data network that's not just leveraged here in Louisiana, but across the South and other states across the country. And we've led this or been the coordinating center with many large health system partners from across Louisiana since 2014. And it really enables real world patient centered research that is really used to make improvements in public health policies and programs. And as I mentioned, these advancements really show how Louisiana transformed crisis into capacity, both on the programming side or how we practice, healthcare service delivery, and then also on the data side as well. So, as we look ahead, I believe one truth remains constant that health is the foundation of resiliency. Without it, our people and our communities cannot they cannot rebuild, and they cannot thrive. So today, we know more than ever we continue to confront deep and persistent inequities that determine who has access to care, who can afford it, and who is left behind when the system shifts or when funding gets pulled from underneath us. We also know, where we live in the Gulf Coast, we also face growing threats from climate-driven disasters, extreme heat, and other disruptions that disproportionately impact people across our state, particularly people who may be lower income, who may be in rural communities, and may be in historically social marginalized communities. And at the Louisiana Public Health Institute, we continue to work not by ourselves because we know we can't do this work alone, but really within a coalition of partners to defend against the harms caused by the OBBA and its impact on Medicaid, particularly ensuring that Louisianans can maintain their coverage and access to care. We're also doing a lot of work around efforts in the maternal child health space because, as we know, in Louisiana, we have some of the worst maternal mortality outcomes and infant mortality outcomes, and certain populations like Black women are disproportionately impacted by maternal mortality and infant mortality. So we've been doing a lot of work to promote the role of doulas in supporting families, as well as promoting community health workers across the state to support families and act as an extension of care teams, both within community-based provider organizations and health systems, to really strengthen families and really help us improve our maternal and child health numbers. We're also tackling youth tobacco. Before, we were doing a lot of work in general tobacco use, really focused on commercial combustible tobacco. And we know we have made major progress in adult tobacco use. But now, with vaping being on the scene for the last 10 years, we've seen a dramatic increase in youth tobacco, particularly around vape use, both in vaping only and dual use of vaping and combustible cigarettes, which continue to be on the rise, and actually the highest, higher than the national numbers. So we know that in order to address these issues, we must begin to really prioritize and engage young people and the people and adults who work with young people to, to really help them with cessation. Additionally, we also know that, as I mentioned before, we can't just focus on physical health when we're talking about health. We also must make mental health a central part of overall public health programming, and we're doing that through offering, free mental health first aid training programs for anyone in our community, so they can recognize if a neighbor or a family member or another loved one is having or experiencing a mental health crisis or substance use challenge, and they will know where to link that person within their community to a provider that can help support them in that mental health challenge. Additionally, through it all, I know one of the big things that I do, especially as my role as the board chairwoman of the New Orleans Chamber, is really reminding our business leaders and our policymakers alike that economic opportunity and community health are inseparable. And our state's long-term prosperity really depends not only on thriving industries, but also on the health and resilience of our people and our communities. So, as we look ahead to the here and now, our work is about more than just rebuilding systems. It's really about reimagining what these systems really look like when they really work for all Louisianans, and what ensuring that every Louisianan has fair and just opportunities to be healthy and well really looks like for every community in Louisiana. So we're really doing that by centering community voices and communities most impacted by health burdens like chronic conditions, environmental challenges, by ensuring that community voice is at the center, communities' lived and living experiences are at the center, and allowing that to really guide where we prioritize on the public health side. As I shared earlier, we're really working to bridge both the data and research infrastructure and pair that with, public health programming and culture, the culture that is here across Louisiana, recognizing that evidence and data and empathy must move hand in hand. We're also rooting our efforts in both policy work and people, understanding that we know that, we can pass policies that improve health, but we also must work to ensure these policies are implemented effectively to support communities as well. And then, lastly, we know, and I know that the storms may have sparked transformation, but it is our continued courage and our continued collaboration and partnership that will sustain this transformation as well. So with that, I will turn it over to our next speaker.
All right. Thank you, Shelina. I'm just chiming in to help us transition to our next speaker. We'll now hear from Mike Bertaut with Blue Cross Blue Shield.
All right. Thank you so much for having me here today. Let me make sure that my slides are coming through all right. You guys see that okay?
We're seeing the presenter view rather than the full screen. If you want
Well, we can't have that. How about if we duplicate it? Not better?
better. Thank you.
Okay,
Yep.
great. For those of you I haven't met, my name's Mike Bertaut. I'm an economist and I work for Blue Cross and Blue Shield of Louisiana. I've been with Blue Cross, actually started in the fall of 2004. So when Katrina hit, I had been in my job less than a year. I grew up in Morgan City, was born there, raised there. So we were kind of dodging storms pretty much my entire childhood. We really didn't set our worst case scenario high enough to account for what we saw between Katrina and Rita. I was living in Ascension Parish when the storm hit, had relatives who lived down in New Orleans who were drastically affected by the storm. We started to house evacuees. We had just built a new home, and we ended up within a month, we had 23 people, 10 dogs, and a bird living with us, most of whom we had never met. They were just friends of family members, and their homes were destroyed and they were devastated. And so, we had a very tragic front row seat to watching these folks rebuild their lives. And my wife was just amazing. She opened our house, took care of them, put their kids in school with our kids, wanted to make absolutely sure that I could work because we were staying very busy on two big projects here at Blue Cross during the storm's aftermath. Number one, we lost track of 60,000 people with Blue Cross cards in their pocket that we could no longer find. They weren't paying premiums. We didn't know where we had landed. And fortunately, our board of directors, which is a community based board, we're not a publicly traded Fortune 500 for profit entity. They decided back then that they were going to keep these people enrolled and pay their health claims as they came in, whether they paid us or not. And so for at least 6 months, we had tens of thousands of people that we were subsidizing as we found out where they had landed. And the dispersion was manifest. People in Utah or Canada or Georgia or Texas, California, it was almost every state in the union had received evacuees that were using healthcare wherever they landed. And fortunately, because we had network everywhere, we were able to take care of them. I was very impressed with this, having only been with the company for a year, and also having come from a Fortune 500 company who I was comfortable would never have paid for claims for 6 months for customers who weren't paying premiums. The second thing we noticed is that because of the infrastructure and devastation in the New Orleans area, there was no way for us to pay the hospitals and the doctors through conventional means. Their banks were flooded, the power was out, they couldn't get to their electronic funds. So we literally started to bring cash down to New Orleans so that they could make payroll, so that the nurses and the doctors would have money so they could keep working all during the time of the devastation. And it just solidified in my mind the value of the mutual not for profit model for health insurance. Very impressed me. And, even 21 years later, I can remember how it felt to be able to help those folks um, in the worst possible times, worst time it could be. As we went forward during the process, we did a lot of work with hospitals trying to build their bed counts back up, to help them find nurses and staffers who could come to help support and build housing. It was an all hands on deck effort for years after the storm, and it took a long time for people to recover. We had a lot of people who worked for us whose houses were flooded. A lot of them didn't get back into their homes for a year or 2 years after the storm. So we know what kind of a fight it was. And, you know, I I was fortunate to be there with a front row seat so that I could take the opportunity to make sure that we were doing everything in our power, physically, financially, emotionally, to get those parishes back on their feet and to get their medical infrastructure up and running again. And it was a privilege to be a part of it, to be honest. after what we had seen before. What I'd like to do is to kind of fast forward a little bit and let you know some things that happened after the storm that I think really changed the landscape here in Louisiana. The first one was when the Affordable Care Act passed, and we were actually able to open up individual health insurance coverage to people with huge amounts of federal assistance and without regard to their own health status. So nobody was asking them, starting in 2014, nobody was asking medical questions anymore. Nobody had to pay all their premiums out of their own pocket. We enrolled about 100,000 people in 2014 that we're comfortable had never had health insurance in their entire life. And you could tell by the guidance that we gave them that they really needed someone to guide them, to hold their hand, and to make sure they understood this is a primary care doctor. This is going to be the guy who leads your care. This is going to be the lady who makes sure that you get all of the things that you need. And that became the battle, how to get people to move forward in that environment. And then almost immediately, within a couple of years after, we took up the Medicaid expansion that was offered under the ACA, which allowed the state to expand care to another 400,000 people almost for free. 90% of the money was paid by the feds. The state put some taxes in place that covered the other 10%. It was the Medicaid expansion was a huge boon for Louisiana. And we were thrilled to see people, again, large populations who'd never had care anywhere outside of an emergency room, all of a sudden have access to doctors and specialists and clinics and treatment and drugs to maintain their conditions. Huge battle, huge going forward for the healthcare system in Louisiana. Today, when I look across the landscape, I'm often reminded of one of my heroes, what Dr. Walter Williams said about healthcare in the United States, specifically in Louisiana particularly. He said this. He said, we have managed here in America to build a world-class, technologically advanced healthcare system with global reach that is the envy of the world. When people get sick, they want to come to America to get treatment and to get well. But in the process, we didn't do a good job of building it in such a way that people could pay for it out of their own pocket. And so we are in a situation now where we're completely dependent on third parties to pay for healthcare when we get really sick. And this is my best estimate of the outlay of the third party payers in Louisiana and the membership of our citizens. So you can see here, I think today, Medicaid has about 1/3 of the population enrolled, a third. If you look across the way, you see Medicare at about 16% of the population. You add those together and you're nearly at 50% government enrolled. If we throw on the VA and a few other programs, we easily have the highest percentage of our population enrolled in a third party payer that's a government managed program. Now, why does that matter so much? Oh, I want to point out one other thing. That uninsured at 9%, when the Affordable Care Act was being negotiated, Louisiana's uninsured was over 20%, 21, 22, 23%, depending on which day of the week you took the count. And so that's kind of a direct societal good impact we can see from the implementation of the Affordable Care Act in 14 and then again here in 16, reducing our uninsured down to below 10% of the population is a huge deal. Now, why does it matter whether people are enrolled in government pay programs or private? Well, it turns out that the government pay programs are not really covering their cost right now. And so this is a battle we fight every day. This is pretty recent data. This came from the state of Colorado, where they did a multi-year study to try to determine the relative payment rates on average in a hospital setting or in a doctor's office for the different programs that were in their state. Now, their goal was to create a private insurance program that was run by the state government, so a public option, if you were, and they wanted to find out what would be a fair amount of money to pay hospitals. And the number they settled on was 144% of Medicare, and then they allowed a 10% margin on top of that. And so the program in Colorado today pays hospitals about 155% of what Medicare pays. But if you look below that red line, what they determined was that Medicaid and Medicare were paying hospitals way below wholesale cost. And then on the right, those are doctor fees like going to a specialist. And you can see again way below cost. Now in Louisiana, we make up some of this shortfall in the Louisiana Department of Health with directed payments, cash payments that go directly to safety net hospitals to help them bring that number up to the point where they can afford to keep operating, even though the majority of their patients are Medicaid or Medicare patients. Yeah, you heard Shelina talking about the limitations under the OBBBA, the One Big Beautiful Bill Act. One of the ones they did was it put a cap on how much departments of health like ours could pay a safety net hospital in these directed payments. And that's going to cause stress inside the LSU system that we're looking for a way to alleviate even as we speak. Notice the gray bar, when Blue Cross pays a bill, we tend to pay, well, we tend to pay a lot more than 150% of Medicare, but we also are paying a larger share of the market than the public options pay, just because we have to negotiate with hospitals and doctors before we settle on an amount. They don't have to join a Blue Cross network. And when you look below at Medicaid or Medicare, there's no negotiating really going on there. They've got a fixed payment schedule and they pay. So when you engage in private health insurance and you notice it's going up pretty quickly, this is a cost shift. This is part of the reason that you see private insurance becoming so expensive. When I joined Blue Cross back in 2004, this was how we spent premiums. And you can see how the money went out the door that year, 2004. 38% of the money that we took in paid a hospital bill directly. 34% paid for doctors and outpatient services. We were able to buy everybody's drugs, all of the medications at the pharmacy, at the doctor's office, or in a hospital for 11% of premiums. And then the total overhead in the system for taxes, for salaries, for commissions, for funding our foundation, all of those things required about a 17% contribution. Now I'm going to fast forward 20 years and show you what this number was last year. And what you're going to see is we're in a very different business than we were in 2004. Here's the 2024 results. Same dollar bill, about double the amount of money coming in the door. Premiums roughly doubled in those 20 years. And you can see hospitals getting about 34% of the money. Physicians and clinics and outpatient, their share has gone down. The total amount they get has gone up, but their share has gone down. But look at drugs. This is the battle we're fighting every single day. Prescription drugs went from 11% of the money you're spending on premiums to 32% over the last 20 years. And the majority of that inflation is in the last 6 years. So our daily battle to try to keep healthcare affordability is increasingly revolving around getting control of how much money we spend on prescription drugs. And I can tell you, we put a lot of effort and a lot of energy into it. It's a battle we'll fight every single day. Once the Affordable Care Act passed, private insurance companies like us are required to spend at least 85% of the money they take in on nothing but healthcare. And you'll notice last year we spent 14% on overhead. About 6.5% of that were salaries, benefits, and running 8 regional offices. 3.5% for commissions, because 85% of our members out there that get their insurance through work are represented by an agent, a broker, or a consultant. About 1.5% of it went to taxes. Last year we were blessed by being able to put a little money in our rainy day fund, because we can't issue stock, we can't borrow money. If we have a bad year, we have to have money in the bank to cover us. So this is the output from 2024. I also want to point out that we've got new thresholds. We're in open enrollment right now for healthcare.gov. We're in the annual enrollment period for Medicare Advantage. So you can change MA plans right now, no harm, no foul. The Medicaid is essentially always in open enrollment. And then on healthcare.gov, you can buy insurance today using federal money without having to prove any evidence of insurability. And you can change plans for the next 6 weeks. Pretty much no harm, no foul. On the left-hand side, what I want to show you is these are the Medicaid thresholds for income next year. So our 2026 results. Notice that for a family of 4, The adults in the household can come into Medicaid at about 45,000, 44,000 a year, and the children are covered all the way up to that household's income of $71,000. The average household in Louisiana with four people in it is about 60 grand of income. So you can see a large swath of our population, almost half, very heavily dependent on Medicaid to make sure that they have a third party that can take care of them when they have an illness or a chronic condition that really needs taking care of. And we monitor this very carefully, and we want to make sure that all of our public facing assets are well aware of these thresholds. We believe there are thousands of people wandering around out there who are Medicaid eligible and have no idea. They just really don't know what the numbers are, and they haven't tried. And let me tell you, Medicaid is a great fallback for when you're not doing well. So we want to raise awareness. We want to make sure everybody knows these numbers are not being affected by anything in the OBBBA. They're not being affected by anything else. These numbers are locked down and they weren't manipulated or changed in any way in any legislation. We are concerned about the fact that advanced tax credits on healthcare.gov that were accelerated, enhanced just a few years ago are sunsetting on December 31st. And once that sunset takes place, people who are in these brackets, well, you can see from the grid what their status is, what their income is, and how much their annual cost is going to go up for their health insurance in 2026 if Congress does not reach a deal where they can figure out how to continue the current tax subsidy level for the next few years. Another thing that you need to take into consideration there, we've done the analysis. We believe that the failure to renew these tax credits will generate $1.1 billion in shortfall that would have flowed to Louisiana in premium money. And I just showed you what happens if you gave the billion to Blue Cross. What would happen to it? 350 million would go to a hospital. 250 million would go to doctors and outpatient services. Another 300 million would go to pharmacies or to doctors' offices who dispense drugs. So that missing $1 billion will have a huge impact out in the world when we start talking about spending and support for hospitals, for doctors, for pharmacies, and for infusion centers, things like that. So we are watching very carefully. There's only a few weeks left for Congress to approve extending these tax credits beyond December 31st of 2025. And the impacts in Louisiana will be huge simply because we're not a very wealthy state. And so we're more dependent on these tax credits here than most other states are. It's going to be a very big deal. I do want to, I know I've shared some scary stuff, but I want to encourage you to not give up on change, right? That picture that you're looking at there is my kitchen, mine, from my house a year ago. At the point at which my wife, who's retired and brilliant, came home and said, "You know, Mike, I hate this kitchen. We really need to remodel it." And I said, "You know what, honey? Whatever you want, we'll get it done." 3 weeks later, I'm standing in the middle of demolition, right? All those cabinets are on the ground. All of the tile is picked up. It's dusty, it's messy, and I'm worried, right? I'm standing in the middle of it going, have we made a mistake? What are we doing here? And you know, my wife, she came over and she took my hand and she said, "Relax, Mike, I got it covered. It's going to be great. You're going to love it." And my first thought was, "You're crazy." But I said that to myself. I didn't say that out loud. So she was right, of course, just like always. 2 months later, this is my kitchen. So I've learned, and I'm learning the hard way, not to be scared of change because sometimes you end up way better off than you were before. Got all my contact information there, but I think that'll do it for now, Stephen. Thank you so much for the opportunity.
Excellent. Well, thank you for your remarks, and I think you've ended us on a good note because I think absolutely the theme of the discussion and kind of what we've hoped to prompt with all of our Katrina Forward programming is thinking about not only this unique moment in the state's history and remembering the devastating impacts of those storms, but really remembering and kind of understanding ways in which things can change in a big way, not always for the better, but sometimes for the better. And then, of course, with the passage of time, as both of your presentations highlighted, the healthcare system has been changed in really dramatic ways, and I think in many ways that have given Louisianians better access to care. But of course, this is an environment that is continuing to change with lots of big potential changes on the horizon. So I do want to kind of bring that conversation back to some of that big picture thinking about how things have changed and what the path forward might look like. I'm certainly want to open the floor for questions from the audience. So attendees, please feel free to drop some of those into the chat. I'm going to start us off though with a question that I had, kind of thinking back to the context of the storms and something that I think you both certainly touched on is this idea that in responding to crisis, sometimes you see new opportunities for bigger changes, and that could be drawing down resources to invest in infrastructure, or ways in which we've seen the storms shift the way care is provided in very specific ways. But I'd like to hear each of you maybe relate that to a more current context as we think about infrastructure needs in the modern healthcare system. Even if we're not responding to a storm or disaster in the same way, is there a big need that we could identify in terms of a need for additional infrastructure? And I think in your remarks, Shelina, you talked about not just maybe physical infrastructure, but data as an example of that too. Is there infrastructure that we need now that could be added to our healthcare system or expanded that we could then benefit from for many years, that might only need a one-time investment?
I'm happy to start. So one that I can think about, and I didn't reference it specifically, but I know last week, in partnership with a number of partners across the Gulf Coast, we put a proposal. We submitted a proposal that really focused on solar infrastructure on community health centers. So we know that when we lose electricity after a hurricane, it can be really detrimental, not only for communities, but also depending on if a community-based organization or health system doesn't have that infrastructure, like generators and things like that, that could also have health impacts, not just on the people being served, but also on the storage and maybe if there's medications that need to be refrigerated, it could cause like significant financial loss for that community-based organization. And so what we are working in partnership with the primary care associations across Louisiana, Mississippi, Alabama, and Florida on is really, pitching a proposal to retrofit community health centers in some of our most impacted, hurricane impacted areas, to really support them in becoming completely off grid by retrofitting them with solar. So that's one aspect, and these entities are called health resilience hubs. We actually have one federally qualified health center that is already a health resilience hub, that is Crescent Care in New Orleans. And we'll really be leveraging their expertise and guidance to kind of demonstrate how this has actually, helped them to save financing and funding, because they are able to, get credits because they are completely off grid, and also helps them to stay open for the patients that they serve. So we'll be doing that, but then also using the data infrastructures that we have to really monitor and evaluate the impact on health outcomes for the patients that are served in these community health centers. So I feel like infrastructures like that, like really thinking about what is needed during time of a disaster when we lose electricity, for example, and how that supports, health resiliency is one way we have done that.
I think that's brilliant. As a big proponent of solar, I have it right here on this house, right here. Make sure you buy the batteries. to go with it, because if you don't, when the solar cells kick on, they disconnect you from the house. So you've got to have the batteries to store the power. I've learned the hard way. Um, the other thing that we were really looking at hard is I'm on an advisory board on medical schools, specifically FranU and a couple others, because one of the things we've identified is we had really hoped that with the ACA that we could bring truth to the that.
Mike, I think yeah, we're having maybe some internet hiccups. It looks like your video might be freezing every 10 seconds or so for a few seconds.
Oh, I'm sorry. Yeah, it says my connection is unstable. Can you hear me okay?
We're hearing you well now. If you
Okay,
yeah,
great. Maybe I should talk at a slower pace so the internet can keep up with me. Um, the reality is that we still feel like that there's a large population of people who are not getting appropriate care for their chronic conditions, because they're not using primary care resources, either because they don't have a relationship with a primary care doc, or their primary care asset is retiring, or has moved on somewhere else, or left the state. And so, how can we do that? So we're investing in trying to get primary care extender programs added to places like FranU, or places where we have local education. Because what we've discovered is, depending on the school, there's a big difference between somebody graduating with credentials at one location and their likelihood to stay in Louisiana. Some medical schools we've noticed the graduates have a foot out the door before they're even done, and they'll never stay here and take care of our people. So we're trying to focus resources on populations of folks that want to go through the training and get smarter, but want to reinvest in Louisiana, because that's what we need more than anything, I think. We're trying to learn when we talk about social determinants of health. You're asking an insurance company to get into areas where they have very little expertise, but they have resources and they can learn. And so we're trying to see what we can do beyond our normal functionality, right? To help people avoid hospital stays or avoid these long term physical and mental conditions that are brought on by things like food deserts, or brought on by a lack of air conditioning, or brought on by transportation issues. We can tackle some of that stuff. It's not in our normal remit, but you know what? We've got smart people who work hard, and they've got an opportunity, they've got a chance to reach into those areas and change lives. And I'm pushing them as hard as I can, as hard as I can.
That's great. Thank you. I'm going to add. I'll add one more to the infrastructure pile, and that is broadband, which wasn't one that was on my mind. But as we were talking, I was reminded, as I often am, that not only is high quality, reliable, and stable broadband critical for all sorts of information exchange like this, but as I know you're both well aware, it has become so central in the delivery of healthcare and is increasingly relied upon, especially in more rural parts of the state where broadband is not available. That remains an obstacle, and I think certainly an interesting and important area for future development. Um, and that brings me to another topic I wanted to ask you both about, and then we'll go to some other questions from our audience. But I wanted to spend a little time thinking about rural parts of the state. I think you both touched on some related issues that kind of introduce this as a vulnerable area, perhaps even more so now than it has been in many years. Recent federal changes in Medicaid that may lead to fewer people covered through Medicaid, as well as caps on payments to safety net hospitals. Could I'd like to hear from each of you about where you see, as we think about a vulnerable system where changes could threaten the viability of sustaining a larger facility like a hospital. What do you see now in the rural landscape as in terms of major areas of concern, and what can we do to try to address those things?
I think one of the battles we're going to continue to fight is, um, we have plenty of rural parishes, probably 40 of the 64 parishes in Louisiana have less than 20,000 people in them and have one hospital that's struggling, hanging on by its fingernails to stay open. It might be the largest employer in that parish. And its impact is not just as a way station for cases that are on their way somewhere else, but also as an economic engine, as an employer in that area where they are critical, really, to supporting the infrastructure and the tax base of that area. So it's how do we figure out a way to make sure that those hospitals have the capability, the connections, and the data to do what they need to do to remain viable. We also want to help them find funding. I read this morning that all 50 states have applied for the $50 billion Rural Health Fund that was created back in July. All 50 states. Now, I think it's fair to say that the need might be a little more dire in Louisiana than in Massachusetts or Rhode Island or a state where the average household income is 80 grand a year or 90 grand a year. So I think that we need to be vocal about making our case to make sure that that money flows into areas that are the most needy. And I have to put us pretty close to the top of the list.
And I just add, I mean, on the hospital side, I think about women's health in particular. I mean, we already know that Louisiana has a large maternity care deserts in terms of, I think about 1 in 3 or 1 in 4 of our parishes actually are a maternity care desert and do not have a women's hospital and don't have OB-GYNs to serve patients who, are birthing or pregnant. And I think that is also something that we need to really pay close attention to because we already had a crisis before now. And we just have to pay attention to that, especially because as I shared, early on, our maternal mortality and infant mortality statistics are abysmal in the state of Louisiana. So I really think that we need to pay attention to if hospitals are closing, well, how do we keep hospitals open? And of those that are open, how many can then provide care to women, through their, pre and postpartum journey? And then also, where are there alternative approaches in rural communities, maybe like partnerships, mobile, what are some of those alternative approaches to providing care when we can't get a hospital open in a particular area?
Thank you. I'm gonna go to one of our audience questions. Home visiting programs like maternal, infant, and early childhood home visiting continue to demonstrate robust evidence of prevention, but could face future cuts from lower federal funding. Is there a sense of what's happening to Louisiana's reliance on the funding for home visiting, and what will happen to prevention programs like it if funding changes or goes down?
I could just speak from LPHI's perspective. We're an implementation partner in the Go Far Coalition, which is really focused on, improving early childhood, both education and on the health side. And to your point about, the home visiting programs, we're working very closely. One of our goals is focused on enhancing home visiting programs. To your point, I'm not sure how the federal cuts will impact that, but I know that there are pilots happening across the state of Louisiana to really support and uplift home visiting programs. So one right now that is happening in the New Orleans area with the New Orleans Health Department and New Orleans East Hospital is the Family Connects program, and that is being funded, I believe, by the city. And I know that there is also work happening with Susan Nelson's organization as well to support home visiting. I think the biggest thing is how can we advocate, at the state level to continue to fund these programs. That's basically what we're doing. So if you are interested in learning more for the person for Jordan who asked that question, I'm happy to connect you to our Go Far Coalition partners to see if there's additional advocacy or things you want to be engaged in.
Yeah, completely agree. Also, I was very encouraged this month because 5 years ago we set up our own telehealth doc service, right? So people could remotely access care and get what they needed. Well, we set ours up because nobody was really taking the initiative. Now, every clinic, every doctor's office, every hospital has set up their own telehealth assets, and it's gotten so widespread now that we are going to shut ours off because nobody's using it. They've literally moved that capability away from the care insurance payer directly on to the provider, the medical providers. And that's where it should be anyway. So I'm very excited about how broad that's become. I promise you, if you have a doc, you should ask them about telehealth. They don't always advertise it or make a big deal out of it, but just about every clinic and just about every hospital in the state now has access to telehealth resources and assets.
That's a great example of just how much the system can change, and this has been a theme we've talked about several times over. And I wanted to come back to thinking about the system as a whole, and then the broader view on the health of the people of Louisiana. And I know kind of some of the really standout examples that you shared, Mike, about in the immediate aftermath of the hurricanes, Blue Cross Blue Shield kind of going outside the formal system, right? So we think about the US healthcare system and the role that insurers play and the role that the government plays. And I think for a lot of people, that system is intimidating and difficult to navigate. And so we can see breakdowns in that system. So it's amazing to hear stories of a large insurer kind of going above and beyond to try to help overcome or compensate for shortfalls in the system. And of course, the Louisiana Public Health Institute is doing an enormous amount of work and helping to build coalitions within the nonprofit community to try to help fill gaps and address shortfalls in the system. I wanted to have an opportunity to kind of just hear any recent anecdotes or stories or initiatives. And I know you talked about being engaged in workforce development, and thinking about how to expand training programs. But other examples of ways in which maybe Blue Cross even today is kind of doing things to help push the system forward or supplement the system. And then again, Shelina, I'd love to hear your thoughts and examples there on ways that nonprofits and smaller organizations alike can kind of contribute to um, shoring up our broader access to care and improving public health.
The most important thing that I can convey to people today is that we are kind of taking a step back and looking at the basic blocking and tackling, the basic nuts and bolts of people actually achieving care states. And the first step in that today, I'm afraid, for better or worse, is do you have a third party payer that you're enrolled with? Do they have your back? Because I promise you, if you don't have somebody with deep pockets standing behind you when you have an illness, you're in trouble. You're not going to get the care you need. The system responds to enrollment, whether it's Medicaid, Medicare, the VA, Blue Cross, any private carrier, whatever. The system is set up for enrollment. And as soon as you walk in uninsured, you get treated like a second class citizen. And that's not fair, and it's not equitable, and it's not right, but it is what it is at this point. And so, this time of year, when all of these enrollment opportunities are on, that's all I'm going to talk about. Why haven't you enrolled? If you have family members, and everybody has them, who are wandering around out there uncovered, right? And when they break their leg or something, you're going to be the one that's going to have to take them to the emergency room and probably pay the bill for them. Get them enrolled. I mean, it's never been easier to have a third party at your back right now. It's never been cheaper to have a third party at your back right now, Medicaid, Medicare, or private coverage through healthcare.gov. So I'm going to sound like a broken record for the next 6 weeks because this is the opportunity. And I don't think there's anything you could do for your health that's more important right now than having that backup when you need it.
Yeah, and
Thank you. Yeah, we're short on time, but I want to give you a minute or so
oh,
for a
sure. I'll
closing
just
thought.
briefly, I mean, to add to your point from the almost care team member side, there are new types of care team members that are now being reimbursed, particularly under Medicaid, like community health workers and doulas. And one
Yep.
thing that we're doing at LPHI is really figuring out what are the barriers that, that might, the barriers that may help, or barriers or opportunities to help connect those doulas to the credentialing process or connect community health workers to the credentialing process so that there is an enhancement because we know that there's a shortage of physicians and other types of providers. So how can we leverage these other care team member enhancements that I call them to support overall health is a lot of the work that we're doing as well.
Well, great. Well, thank you both again for your time today. I really enjoyed hearing your remarks. I know our audience did as well. For anybody listening today who did not get to hear in our earlier Katrina Forward webinar series, or there are recordings from our in-person symposium on August 5th as well, I would encourage you and those of you who might be watching this or listening to this online later on to check out the Blanco Center's YouTube page and get caught up on those other events where we heard some very engaging discussions on other topics. But thank you all for your time today, and please visit our website to subscribe to our newsletter if you have not done so yet. All right. Thanks, everyone.
Thank you.
Bye.